Hey, Sandra. Can you tell us briefly about the Zero Suicide Initiative and how patients and families were involved in the design and implementation of it at St. Joseph's?
So zero suicide is both an aspirational goal and a practical framework in order to develop system-wide transformation for safer suicide prevention care. And right from the beginning, we had both frontline staff and patients and families involved, both in the planning and the delivery. So, we learned a lot in doing that work, and an example I often share was we had gone in using the framework as it had been described by the Henry Ford Hospital, where every patient would have a crisis plan. And at one of our beginning working group meetings, we were told that having a crisis plan may have implied that every patient would go into crisis, where the reality was all of us need to know how to cope. So things we should gravitate to when we're stressed and things we should absolutely avoid. But it was those key things and that key information that I think really helped our plan develop.
Can you share some of your lessons learned from this initiative about how to effectively partner with patients and families?
So one of the lessons that I personally learned was that I'd often been involved in steering committees that had healthcare providers and hospital administrators. And this was the first time that we had a fairly significant patient and family involvement right from the beginning. So they were core not only to our working groups, but also to our steering groups. And our first meeting was a lesson learned, and I think partially because the topic was about suicide when you had people present who had either made an attempt on their life or people who had lost loved ones to suicide. It was quite emotionally charged, and the other thing that we learned is we asked patients and families to come and say, how can we improve the care we deliver, which meant they often shared how care may not have been ideal, years previously. So after our first steering committee, we actually devised time so that if you were a patient or a family member who needed to speak to someone because the information you shared or you heard had been, had really triggered or been re-traumatizing, that there were people to speak to. Similarly, if you were a clinician and you heard that, that perhaps the care you provided was not seen as ideal, there was also an opportunity for a coordinator. And that made sense, so that was kind of what we developed after the first meeting for the second meeting. But then the other piece we learned is that not everybody was comfortable sharing in the larger group. Maybe they didn't want to hurt a clinician's feelings, maybe they didn't want to be seen critical of a patient in any way. So that was the other meeting that happened after the meeting when we allowed ourselves and to be available to people after our steering committee. And I would highly recommend that for any scheduling of steering committees that involve patients and families, that there needs to be an opportunity for people to debrief afterwards.